So resistance to CAR-T is an important topic, and I think a lot of what we have learned is from the lymphoma world, but again, a lot of data has been generated in ALL as well. And I think there are many factors which can come into play into the resistance to CAR-T. I think at the time of relapse, it could be a CD19 negative relapse, where CAR-T cells, ALL cells have lost CD19, or it could be a CD19 positive relapse. If you have a CD19 negative relapse, I think the strategies then management subsequent to that becomes different, because then you cannot use drugs which are targeting CD19, such as blinatumomab and others. If it's a CD19 positive relapse, then in that case, you could potentially look at other therapy options for those patients, including CD19-directed therapy. Now, in terms of upfront, how do we design CAR-T to prevent these relapses? I think some of the strategies which are coming along are dual targeting. You target two different antigens, which hopefully will prevent occurrence or emergence of a relapse, which is CD19 negative. So if you have a CD19 and 22 together, hopefully patient will not get a CD19 negative relapse, because the CD22 will take care of that. So that's, I think, one of the potential strategies which are kind of being investigated in clinical trials right now. I think the other potential thing will be, we know that if the tumor burden is less for a patient going into CAR-T, they tend to do well. So I think one of the approaches would be to try to debulk the patient, get rid of the maximum tumor with chemotherapy, target therapy, whatever you think is appropriate for the patient, and then do CAR-T when the tumor burden is low. Those patients are likely going to do well, less likely to relapse after receiving CAR-T.